Welcome to the Scottsdale Top Docs podcast, where we share a mission to improve access to care and prevention, as well as planning for the future. Our goal is to help people live healthier, happier, more informed lives. We believe that healthcare isn't a job, but a calling to serve, and the best care begins with conversation. Now on to today's episode. Hello, and welcome to today's episode of the Scottsdale Top Docs podcast. I am here with my fellow board member, who's the Board of Operations, Dr. Shana Johnson. She is a physical medicine and rehab physician, and we're going to get into what that means. If you've never heard of PM&R, we're going to get into the nitty-gritty of that. And also, she just joined us this year as one of our board members for Scottsdale Top Docs. And Dr. Shana, I wanted to ask you, how has Scottsdale Top Docs been for you?
Oh, Scottsdale Top Docs has really brought me into the community in a way I couldn't have predicted. It's connected me to many opportunities.
How did you hear about Scottsdale Top Docs?
So I actually heard about the group from another member of Scottsdale Top Docs, and I have recently moved here from Washington, and it's really the group that engaged me with the healthcare community and has since led to connections where I have a new role teaching at the medical school, which was exactly what I was looking for my next step. So it's been great for career growth and personal growth. And I also have interest in media, and there's lots of opportunities with medical journalism as well.
Yeah, so I loved our very first meeting. Dr. Adnan Saithna, who's a globally recognized orthopedic surgeon, he's amazing, introduced us, and he had actually already given you his full vote and backing for becoming a board member. And he was our prior board member. So it was just a natural next step. So
Yeah.
I knew immediately you were highly personal. I loved your backstory quite a bit. I love that you're a working mother, you're a dedicated mother, you're also a physician. I know that people know that doctors are real people too, but sometimes we don't think of them as like-minded individuals. And so one of the things that I do love to show is like, hi, this is another human being who cares about your needs on a human being level. And I think if anybody exemplifies that, it's definitely you.
Yeah, I'm exceptionally human. Yes.
Exceptionally human. Yeah. So I also am loving watching this journey you've also been on. I know that you're an author. We're going to talk about your book in a little bit, Sunbreak, Healing the Pain No One Can Explain. And so first, I think let's get into physical medicine and rehab, PM&R. So what is PM&R?
Yeah, so PM&R is a medical specialty. We have our own residency programs across the country. And physical medicine rehab, each PM&R doctor tends to do something a little bit different. So there's a group that work in sports medicine alongside orthopedic surgeons. There's a group that do chronic pain alongside anesthesiologists. And there's a group that do rehabilitation from neurological disorders like strokes and spinal cord injuries and brain injuries alongside neurologists.
So when I worked in Washington, D.C., I worked at an acute rehab, which is the phase between if you're in the hospital, say you're in the ICU and you had a massive stroke, or I had a police officer that had been shot in the head, or I had a brain tumor. So I worked on the neurology side, specifically like the brain injury side of this hospital. And so the PM&R doctor was the primary physician for these patients inside of acute rehab. And they were so incredibly useful and effective at their jobs that I had never really seen another kind of physician that cared so much, honestly, like in a field where you get to spend so much time with each patient. It wasn't really the time, it was the care and interest in this area. They were so encouraging. They knew too this connection between encouraging a patient in the right direction and telling them just what needed to be done. The other unique thing about this particular facility was that they had neuropsychiatry on board. So they were going through this phase of, hi, I'm injured. And then in acute rehab, they were also in this phase of the first time they were realizing that this could be something permanent that they lived with for the rest of their life. It was just sinking in. And every single person, the PM&R doctor, the neuropsych, the nurse, and all of the therapists were there during this period to encourage that patient that there was more that they could do and exactly what it was that day that they needed to focus on. And I had doctors coming in and talking to my patients during their therapy sessions. I have just never really seen it in any other setting except acute rehab where there was that much involvement surrounding a patient. And these PM&R doctors were heroes in this hospital. And so it just, people don't even know what you do.
Correct.
They don't understand the role or where you work.
Yeah.
And how important it is to look at the whole patient. Okay, so
And it's
I applaud
interesting
you.
you say that because my special interest had always been neurologic rehabilitation.
I love it. It's a little puzzle piece because you can see two patients with really dense, heavy strokes. And you're like, oh, this half of their body doesn't work. But each of those patients has very different ways you can piece together the rehab puzzle and talk to them about their impairments to get them to the next phase. And it is one of the most miraculous areas of medicine to really work in, I think. It really is. You can see massive change in a short period of time. Because like a normal acute rehab phase in the United States is 11 to 13 days. And luckily I actually worked at the hospital that Christopher Reeves worked at.
Oh, okay.
Or was rehabilitated at. And they were so incredibly good at their job that they were applauded every time, for making progress. The whole hospital applauded this department, and it was led by these PM&R physicians that were just amazingly outstanding. So I really didn't even know, and I worked in this setting, what PM&R was and was capable of until I was working side by side with them. And they were so fantastic. So thank you for what you do.
Oh, thank you.
So your specialty is really central sensitization syndrome. And I want you to talk about what is that?
Yeah. So when I was in training, we called it central sensitization. But as we've gained a greater understanding of central sensitization, there's actually been a new medical term coined to describe it so that it's formally recognized as a distinct type of pain. It's called nociplastic pain. And nociplastic pain arises from abnormal processing of pain signals in the brain and spinal cord. And why this is relevant is it underlies and drives the most common chronic pain disorders that are seen in outpatient clinics. So, nociplastic pain often underlies chronic back pain, migraines, irritable bowel, interstitial cystitis, chronic pelvic pain. And this is very pertinent for treatment because nociplastic pain is in the nervous system. So you need to focus that treatment on the nervous system, not necessarily procedures and surgeries.
So that's a common problem is that if you have this and you're having all of these kinds of pain, okay, I've got back pain. Now my stomach hurts all the time. And it's a complex.
Yes.
It's a complex list of my primary complaints, but I'm going to see a guy about my back. And so, of course, the guy that does my back says, okay, well, you marked that you have constipation and diarrhea sometimes, but my job is to look at your back. And so sometimes I'm sure you see patients who are getting surgery after surgery or procedure after procedure, or their medication list might be really long.
The big picture is often missed. Right.
So how common is it?
So it's extremely common. 8 to 10% of the U.S. population has nociplastic pain, about 30 million people.
Wow.
So it's a very common disorder that people don't really know about.
Okay, so that is a massive number.
It is.
That's a massive number. So 1 in 10 essentially of us walking around. And it fascinates me because how many people do you know that have back pain?
Yeah, just think about it. Do you know someone with migraines? Do you know someone with back pain? Do you know someone with irritable bowel? I know someone with all of those. So yeah, it's exceptionally prevalent.
Okay,
Yeah.
so say somebody comes in and they have a bunch of these things that are ticked off. do you automatically go like, oh, this is probably a central sensitization or nociplastic pain patient? How do you determine if it really is? Because like, in like the 90s, early 2000s, everybody had fibromyalgia. You know what I mean? Like
Yeah.
it was like,
Yeah.
and still that word does, like fibromyalgia still exists. And doctors still
It's a
test.
nociplastic pain condition.
Yes. And so it's like, here, I have, 9 of the 12 markers are sensitive,
Yeah.
but maybe even some of those patients really have central sensitization where they're hypersensitive.
Absolutely.
It's fascinating. Sometimes I treat geriatric patients who never get touched. Literally, maybe their partner passed and their family doesn't come to visit and they barely even really get a hug. And then I go in to treat them and their entire body is highly sensitive to touch,
Yes.
to pressure, to vibration, to light touch. And I'm like, the first part is just introducing them to touch again and what normal pressure is. And like, it's a cool process because it can happen really rapidly. Kind of like if you get on a roller coaster for the first time and you throw up, you can actually like habituate yourself to like enjoying that sensation and not making yourself sick. So it's interesting because sometimes there are things that we can do that are really natural to help people with things like sensory issues.
Yes.
But not all of those things are going to be like, I have this tool and this is the result. So where do we go with that? How do you really tell if what you're looking at is central sensitization?
That is a great question. So there are clinical signs that should heighten your suspicion that it's present, but there's also clinical tools that make it really easy. So the clinical signs are, one, it's long-standing. It's been there for months. It's not an acute disorder. It doesn't happen. You don't wake up in the morning with nociplastic pain. It's something that develops slowly over months or years. Two, there's something I call pain spread, which is there's typically a typical boundary of pain when you have a problem, like a migraine or back pain. But when sensitization is present, the pain starts spreading beyond the natural boundary of pain. So for someone with migraines, you might also start having facial pain, neck pain, or even chest pain. With back pain, instead of just your back hurting, it might spread across your back and down your legs. So pain spread is a big indicator. As you were mentioning, hypersensitivity, when things that shouldn't be painful are, that's a sign because it's a sign of a confused nervous system not processing the pain signals correctly. And lastly, non-pain symptoms. When sensitization or nociplastic pain is present, you typically have brain fog, profound fatigue, significant sleep disruption, and you're just really sensitive to the environment, like lights and sounds. So those are the key clinical indicators. The clinical tools that can be helpful are either a pain map where people draw out where they feel their pain. If they've shaded in half of their body, they probably have nociplastic pain.
Okay, everybody's seen what you're talking about. Like you go to the doctor's office and they have that little guy, like the blank guy, and you're supposed to like color it in essentially, like make a couple marks if you're having numbness, tingling, burning, pain, aching. And they have all these little things that you do. And so you're saying if I'm really coloring this guy in a lot, that this could be a sign to my physician.
It's a pretty solid indicator.
Pretty solid indicator. Okay. If you color the guy in everywhere, you might have this.
Yeah.
And so it's not just good for people to be aware that there could be alternative diagnoses. And they could probably ask their doctor about this if it happens to be a person that they're like, wow, this is nailing it for me. I do have all of these. And I can't believe I only went to one kind of provider for this.
I think we're at the point where providers aren't particularly aware of it yet either.
I had actually never really heard of it phrased the way that you phrase it.
Yeah.
Until I met you.
Oh.
I had to go home and do some Googling.
And you work in the field.
I work in the field.
With people with these conditions.
I'd never seen it written on a chart. How about that?
Yeah.
And you're saying 1 in 10. So this is why I'm like, okay, first, the information has to be out there. Like everybody I met, like 10% of the population that came into a PT clinic in the 90s and early 2000s had fibromyalgia. And it literally described people who couldn't move around very well, people who had, like, they were sensitive to light touch even.
Yeah.
Some of them bruised easily, but not all of them.
Okay.
That was an interesting one. But they also were like just generally always fatigued.
Mm-hmm.
It was a lot of things, but one of the best things we could do for them was like assign them an actual walking program. And almost all of them did better immediately when they started moving more and started, it increased their socialization, it increased their drive, it increased participation in all these things they wanted to do. And even that on a big level can help people.
Absolutely.
Like, you just think about if you're having a stressful situation, if we were having conflict right now, we're having words,
Yeah.
and we decided to go on a walk together.
Yeah.
It might help us process what we're stressing about.
Absolutely. Movement is therapeutic in multiple ways.
Yeah.
I also wanted to mention my favorite clinical tool
Ooh.
for identifying nociplastic pain, which is the central sensitization inventory. It's a group of questions. It only takes 5 minutes to fill out, but it's been validated, and people that score over 40 have suggest that a significant amount of their pain is nociplastic. And at that point, your treatment approach really should be focusing on that component of pain, which is much more holistic. It's not an injection or a procedure or a surgery.
So let's get into that. So, you're a doctor who specializes in real medicine in the United States, which means research-based medicine.
Yes.
That it has been determined that for the masses, creates significant change. Now, that means it has to have a lot of information inside of it. It has to be verified. We can't have too many variables. There's a lot that goes into actual scientific research. It's not a case study that shows improvement. Okay, so now that we've dictated that, holistic treatments.
Oh, I see where you're going with this.
Yeah, so my question's just a little bit different about holistic treatments can mean a lot of different things.
Yeah.
But so I'm a physical therapist, and, if I do yoga movements with someone, some people are like, well, I can't do yoga because it's a spiritual treatment. And I'm like, oh, we're not doing the spiritual part of this. We're just using the movements. So let's call it stretching and positioning.
Well, I would take it one step further, and it's about establishing the mind-body connection.
Love.
Because with nociplastic pain, it is exceptionally sensitive to stress and how you're feeling. And if you're like, how could that be true? Well, think about like what triggers are for migraine. Their stress, their noise, their
environmental stimulants.
They're environmental stimulants. So when we say holistic treatment, we mean establishing that mind-body connection, because it's similar for nociplastic pain in the back. When those people are under high levels of stress, their pain levels go up. Also, nociplastic pain is more tied to depression and anxiety. It's a bidirectional relationship where each one truly worsens the other. So it's even more important that those are adequately treated, because if someone has severe depression, it can somaticize and you will feel it more in your back along with your back pain. So making that mind-body connection, treating depression and anxiety, which chronic pain can often cause, is particularly important, in addition to calming the oversensitive, overreactive nervous system that's sending the wrong information to your brain.
Oh man, this
It's a lot.
Literally triggers patience for me, like memories of people who have gone through massive events. And of course, their life has changed forever. And how can they not constantly think like you and I can say, well, I'm going to get up and go for a walk today. And some of them are still in the phase where they think about it and they're dreaming about it and they're working toward something that feels normal and they still can't stand up. They still can't feel part of their body. And of course, depression kicks in.
That
and
is
if
such
I
a
don't
good
ask
point.
about it, if they're crying and I can't identify, help me tell me a little bit about how you're feeling right now. Like
Yeah.
you, on some level, healthcare requires a little bit of time to just be an empathetic provider.
Absolutely.
And it's hard today, if you're in certain areas of healthcare, to have the time, to take the time to advocate in that way. Like,
But they so need it because
yes,
oftentimes, well, what I've been told is there's not that many people that really understand and validate their experience. But that's something that we can provide them, and it makes a huge difference.
I sometimes end up telling my patients, I can know as much as I can about what you're going through, but I am not living your experience. Your wife is not living your
But you
experience.
can
Your kids are
say,
not, but we're here for you.
but you can also say, I've seen 10 people with this,
Mhm,
and this is real,
mhm.
and this is hard. They
That's
don't get
so,
that from other people because a
no.
lot, some of the conditions we see are more rare.
Mhm. Yeah. This is the one area where I'm like, support groups are important. Maybe not to be in forever, but during this certain phase where people are feeling really alone in anything, like there's support groups for people who've lost their spouse or a child. There's people who, like, if you have many forms of dementia, there's there is a support group for almost everything. And I sometimes have patients who fight the idea of a support group, or their spouse is fighting the idea of a support group. And the support group to me is really this thing where you really understand that you're not alone. And usually in that room, there's someone that still has it worse than you. And there's people in that room that might have it better than you. And so you get this, the ruler is bigger than just me. And how more human can we get?
Yeah.
You
And
know what I
you
mean?
also get, I find with these groups, because I have my own struggles in my life uh, with family. And these groups, you've got people that have been working through these things for 20 years, and they have a lot of wisdom to share and a lot of what I call inside tips
Yeah.
that your medical provider may not have thought of
Or ever heard of.
or ever heard of.
It is
Yeah.
fascinating because some people I see 2 to 4 times a week.
Okay.
When you go to your doctor, you may not see them more than once a year. If you have something that requires, for example, an opioid prescription, you might see them once a month. When you're in PM&R, you're getting a much bigger look at things because typically they've seen a lot of providers. So your capture, if they're providing you all the paperwork that you need to do your job really well, might include 10 different doctors, right?
Right. And
Like who have they seen?
it's our job to see the big picture and not get, you know, lost in the knee and just look at the knee, but like how's the whole person doing? And what are this person's goals specific to them?
Mhm. I wanted to go to your tool, the central sensitization
Oh,
inventory. So I've got it pulled
yes.
up in here and we can put this on the podcast, but um, there's 25 questions on it. And essentially you said a score of 40
Hmm.
or more
Hmm.
gets you a likelihood of having central sensitization.
And hopefully, I'm not getting too into the weeds on this, but the reason the score of 40 is important is it distinguishes between predominant nociplastic pain and the presence of nociplastic pain. So, nociplastic pain often co occurs with what we think of as regular types of pain,
Okay.
nociceptive pain and neuropathic pain. So, it's often a mixed pain state.
So real pain, like I have a cut on my foot and it's sending a signal that's appropriate. And this cut is sore and a little achy and burning. And so it's sending some level of discomfort.
What I like to use is like you have back arthritis
Hmm.
and you have legit back arthritis sending appropriate pain signals to your back that says, "Hey, it hurts back here."
Do something.
Yeah.
Help.
And then that back arthritis can put processes in place where nociplastic pain develops. So you've got both of them going on. And so there's a legitimate pathology, if you will. And then you have the nociplastic pain component amplifying that signal and making it worse. And this situation is obviously tricky to treat because you've got two things going on. And so the more nociplastic pain that is present, the less responsive to standard therapies. And the 40 cutoff tells you injections and surgeries are not going to be the answer for this patient. The other way is. If you're less than 40, it's more of a judgment call because you don't know how much of each is really contributing.
Okay, good to know. So you still can have nociplastic pain if you're under 40. It's just saying that you predominantly need to go with hopefully more holistic than just nail hammer surgery.
Yes. And there is a graphic on that continuum of nociplastic pain that we can add as a visual. Because it's a hard concept to process without an image.
I wanted to read a few of the questions from this.
Yeah.
So, and the score is never, rarely, sometimes, often, or always. You have 5 options for the scoring system.
I should give it an introduction so the questions you read make sense.
Yeah, go ahead.
So with nociplastic pain, there are risk factors and contributors to it. And the people that developed the CSI have incorporated those into the measure. So there's going to be questions about mental health. There's going to be questions about specific sensitization symptoms, questions about depression, anxiety, and stress. So it's really a comprehensive inventory of all the things that could contribute to this syndrome. But then the research you said, it's been clinically validated as a good measure. Yeah.
So basically, those are the ones that healthcare providers can use. Clinically validated tools. Yeah. So if your doctor pulls out a tool, usually it's clinically validated. Yes. Okay. So the signs of sensitization, it says in your book, are symptoms persist long past the expected healing time.
Yep.
Symptoms spread beyond the boundary of the injury area. So that's the guy that's all colored in when you go to the doctor. Marked increase in sensitivity to painful stimuli. Okay, so I'm too sensitive for the input that I'm getting. Or it's your subjective report. So it's real. It's real. That's what you're experiencing. But you didn't even think that it should be that uncomfortable. Or your doctor goes, oh, that's atypical. Maybe we shouldn't have that response to this light touch.
Sometimes we call it allodynia, right? Like light touch shouldn't hurt.
Yes.
But
so like
in
I'm
these
poking your
syndromes,
thigh.
it does.
You're like, that's too much. Too much. An overreaction of the system, not of you. Not of you. That's what your experience is. The pain is real, but it's just not typical what we would find for that amount of input.
Right. I think of it as the nervous system is confused. It's like the nerves become tattletales, thinking every little thing is a problem, and they go and they tell the brain, they're like, oh my gosh, we're in danger.
Yeah. And then the last one on this list is non-pain symptoms that cause system-wide symptoms like severe fatigue, disrupted sleep, and brain fog, which you mentioned early. Okay, so here are some of the questions. I feel tired and unrefreshed when I wake from sleeping. My muscles feel stiff and achy. I have anxiety attacks. I grind or clench my teeth. I have problems with diarrhea and or constipation. Again, that's like the back and forth is typically an indicator of IBS.
Yep.
I need help in performing my daily activities. So that's like getting dressed, bathing, cooking, doing the house chores, things I should hopefully be able to do on my own. I'm sensitive to bright lights. I get tired very easily when I'm physically active. I feel pain all over my body. I have headaches. I feel discomfort in my bladder and or burning when I urinate. I don't sleep well. I have difficulty concentrating. I have skin problems such as dryness, itchiness, or rashes. Stress makes my physical symptoms get worse. I feel sad or depressed. I have muscle tension in my neck and shoulders. I have pain in my jaw. Certain smells, such as perfumes, make me feel dizzy and nauseated. That's an interesting one, right? We're just like, oh, we're sensitive to smells. And I have all this body pain. These questions are just so they're just so holistic. Like this, there's one on here. I suffered trauma as a child.
Yes. Adverse
Wow.
child events are known. People who've suffered adverse child events, such as abuse and neglect, have a much higher risk of developing nociplastic pain.
Okay. So, I mean, that's quite a bit more, I think, than 10% of the United States. But yet,
That's
1 in 10 of us could be walking around with this.
And I mean, I think those estimates are conservative,
Mm-hmm.
but that's an excellent point.
Mm-hmm. So, anyway, I just think that the tool itself is it's such a great tool.
Me too.
And even if you don't have nociplastic pain or you don't have we're going to exchange those, the central sensitization syndrome and
Yeah.
nociplastic pain.
It's like we're bridging the old terminology with the new.
Yeah. So, and it's interesting because sometimes terminology scares people. They're like, I don't even know how to say that. But like you could bring this tool into your doctor and sometimes this is a public tool. You can access it.
Absolutely.
So anybody can go online and fill this out for themselves, or you can find it in the book, in Dr. Shana Johnson's book, Sunbreak, the Healing the Pain No One Can Explain. So tell me, what is Sunbreak? Why'd you title this Sunbreak?
So when I was starting to write the book, I was living in Seattle. And in Seattle, it really is great 10 months out of the year. But during the summer, we get really excited because every once in a while, the clouds would part for just like 2 to 3 hours. And we'd actually get some sun, like in January or February. And we called those sun breaks. So the sun break represents like a glimmer of hope and healing.
I think that that's beautiful. I could never live there because I am a sunshine person. So like in Arizona, when it rains, it's like cloudy for 3 hours and then we get sun again and then it pours again. And that's about all the rain I like to see.
Yes, that's why I've relocated. I was like, I need more than a sun break.
Yeah.
I need a sunny day.
I lived in Virginia and it was a complete 180 for me. I didn't even know how depressed I was from not seeing the sun. It was gray. I went to Scotland once for 14 days and the sky turned into the buildings and it was the same color of gray everywhere you looked. And it was really hard for me because I'm just a sun person.
Yes.
So I can definitely relate to this, like just seeing the sun and feeling so good and like the warmth of even relationship. Like it's helpful. It's helpful to know you have someone on your side. So I love this. Your book talks a lot about, the stress, depression, anxiety, how to look for a provider. So what are some of the things if you are a person who has a lot going on medically, you've got multi-system, complex, you're not even sure what, and you've been to a lot of specific providers, what is your recommendation? Maybe they don't know if they have this, but they've got a lot going on.
So I really pause here because it's such an important question. And yet I have a difficult time giving you an answer because, as you were saying, in our current medical environment, it's, see the patient, do the procedure, on to the next patient. And as you were saying, in these types of disorders, they need time. You have to understand their story and understand, where you can help and what components need to be addressed. And there aren't very many places that can do that right now. So I guess, a physical medicine and rehab doctor that has a focus in chronic pain might work, but it's hard to find a provider that can take the time and do this right and keep their doors open.
I like that you say it that way. One, it's gracious because the healthcare system as it stands right now puts a lot of pressure on providers.
So much pressure.
It's not even in my, maybe I'm defensive because I've worked in the system. Like, it's not really their fault. They also have very little power because you're replaceable at that point. If you're not the most productive or you're the least productive because you do care enough to ask extra questions and spend more time, you're essentially the weakest link at your company.
Yes, and I've known pain providers that, the evidence towards how to approach these treatments is pretty solid, and providers want to do the right thing, but the pain clinics that I know of that have tried to do it this way have all gone out of business.
Mm-hmm.
So,
yeah, I could see that. I mean, because it's costly. Time is costly. We
yeah,
don't get any, it really is. Time is costly.
this isn't a 10-minute visit,
Mm-hmm.
and that's what providers have now. So,
One of the things that I do tell patients who have a complex medical history is try to write things down on one page that you could physically hand your doctor when you walk in, that they could like literally scan. I'm not talking about fit as many pages and it cannot be a paragraph, but if you could highlight the biggest things that matter to you and are causing the most problem, that should be on that page that you need to at least visually leave with them.
that's a great idea.
Because often, and I have done this too, I get into an office and I'm like, and I'm answering the 5 questions they have time to ask me. And I'm trying to give them as much detail as I can. And it's impossible. It's impossible. And I walk out thinking, oh my gosh, I had 5 other things I wanted to tell that person.
Mm-hmm.
And I'm a huge proponent of self-advocacy, but I still can't do it myself because there is something about going to the doctor and just feeling like I'm unprepared to answer these questions.
Well, and I think it's hard too because the providers are so rushed that they're almost thinking about what they have to do next, and they have a hard time being present for you.
It is such a weird thing. They have you fill out all these papers and it's like, what's your chief complaint? Here's all your past medical history. And then a provider walks in after a nurse already walked in and they're documenting these things. And they're like, okay, so what are we seeing you for today?
Right.
And you're like, did you read my paperwork? But they really are coming out of another patient. And sometimes they do have a chance to scan through that. And sometimes they do not. And they're pulling the computer up while they're asking you to engage them for what you really need them for. And they want to hear it from you.
But, that's also expecting the client to know their condition and how to treat it, which isn't really a fair ask because that's why they're there, is to sort through what's going wrong and why.
Mm-hmm. It's just such a good conversation about the reality of medicine right now. And like people really don't know what they can do. So I really appreciate your perspective and your empathy as a provider. And I know I know that your altruistic, empathetic heart was the reason that you wrote this book and why you're interested in nociplastic pain.
Well, this is the approach that your providers would take if they had time.
Yeah.
And so it's written down and so patients can try to help themselves.
I love it. Thank you for such a resource. Thank you so much for sitting on the board this year.
I've loved
thrilled to have you. You've been so amazing. I can't wait for more people to interview with you. We have episodes coming out that you're hosting as well. So it's really cool. So tell us just briefly, I actually know what you do, but tell the audience a little bit more about like what you do on the side. I know you do like some writing.
Oh, yeah. So one of my favorite activities on the side is medical journalism and bringing important stories to the public.
So you write for several sources.
Yeah, I have a blog on WebMD and Psychology Today and contribute to medical news about once a month.
Very cool. I love it. I just think that you are like a really humble person and I want to brag about you all the time. So thank you for coming on today. This has been a really fun episode. And thank you for like your candor in this conversation because it's really stuff that has to be talked about.
Totally.
So thank you.
Thank
Appreciate
you.
it. All right. So that has been today's episode of Scottsdale Top Docs podcast. We'll catch you next time. Have a good day.